Hello, my name is Charlotte Kugler and I did this contribution together with my colleagues from different universities in Germany. And I will be talking about collaboration between decision-making bodies and academia in healthcare. And the case I will be talking about was funded by the Federal Ministry of Education and Research. Evidence-based research calls for the use of existing evidence in a transparent and explicit way to prevent research waste. Decision makers should consider the best available evidence, and the best way to do this is to rely on a systematic review. In the past, systematic reviews have become increasingly popular. The most recent study on this came up with a message of nearly 80 systematic reviews published per day in 2019. You can see it on the graphic. Not surprisingly, this comes at the cost of overlapping systematic reviews, meaning that multiple systematic reviews deal with the same or similar questions. Replication is desirable to some extent, and multiple systematic reviews on the same question reaching the same conclusion will inspire confidence. However, overlap leaves systematic reviews users with two major challenges. First, systematic reviews can reach different conclusions. Second, the reporting quality as well as the methodological quality of systematic reviews still leaves a lot of room for improvement. This implies that there's a considerable amount of research waste in the conduct of systematic reviews. From a decision maker's perspective, this can be a very convoluted scenario. Should I use an already published systematic review? Is it reliable, methodologically sound, and does it address my specific research question? How do I choose among multiple systematic reviews? However, if one is not able or willing to rely on other systematic reviews, there's no other choice than conducting a new systematic review, thereby potentially further contributing to research waste. When it comes to policy, we also have to consider the research policy gap. This means that the increasing evidence has to be translated into policy, and the truth is that this rarely happens. Our central challenge is therefore not a knowledge gap, but a translation deficit. Here we may have another problem with research waste when healthcare institutions work independently from academia and therefore even more duplicate systematic reviews to the same questions are produced. Reasons for this are that academia and policymakers have different incentives. Academics are measured by the amount of peer-reviewed journals and attraction of grants. They are not judged by the impact their research has on people's lives. Opposite to that, elected officials are, at least in part, judged by their ability to deliver outcomes that meet their citizens' needs. There's also a communication gap. Most policymakers are not scientists, and thus the language of science is not understandable to them. The two sectors fail to engage and communicate effectively with each other. Failures also exist in project planning. These include insufficient stakeholder involvement in the creation of a research project, investing in pilot projects that are not scalable, an absence of a plan to disseminate and advocate for the research findings to be included in public policies, and a lack of a plan to scale up evidence-based solutions. The aim of this contribution is to show that collaboration between health institutions and academia is needed. To make our case understandable for you, I will briefly explain you the German healthcare organizations. The Federal Joint Committee, GBA for short, is the highest decision-making body of the joint self-government of physicians, dentists, hospitals, and health insurance funds in Germany. It consists of outpatient care provider representatives, the German Hospital Federation, and representatives from statutory health insurance providers. In addition, patient representatives also participate in all sessions but do not vote. In its assessments, the GBA examines patient benefit and defines which specific health services are paid for by statutory health insurance. For appraisal of evidence with regards to needs and costs, the GBA can instruct the German HTA agency, the Institute for Quality and Efficiency in Healthcare, short EQUIC. This institute then collects the best available evidence within a report, which is sent back to the GBA. The GBA can, after verifying the recommendations, implement directives. The case is about minimum volume standards. The GBA sets criteria hospitals need to fulfill to be allowed to perform certain procedures. The minimum volume standards is one of these criteria and defines that hospitals need to perform at least 50 total knee arthroplasties to be allowed to perform these surgeries and to get them reimbursed. So we are now at the topic of knee replacement surgeries. Since there was no high-quality systematic review showing evidence for this directive, the question for our systematic review was: is there a hospital volume outcome relationship for total knee arthroplasties? In other words, do hospitals which perform more total knee arthroplasties per year have better outcomes than hospitals with lower case volumes? We applied for funding at a non-topic restricted call for proposals at the Federal Ministry of Education and Research. And we received funding to conduct the systematic review, which is shown here, in 2018. We registered the review in 2019 on Prospero and published a protocol in the journal Systematic Reviews in 2020. We also presented our results to congresses in Germany in 2020 and 2021. So far, a rather normal procedure for a systematic review, one could say. However, in March 2021, the GBA, so the decision-making body of the German healthcare system I just presented, decided to instruct the independent institute with a rapid report investigating the exact same question. Is there a relationship between hospital case volume and outcomes for total knee arthroplasties? The EQUIC then started the report and performed their last literature search in June 2021. In September, our systematic review was published and we presented the results on another conference. In 2022, so this year, the EQUIC completed the report and published it in March. In this report, our systematic review was not even cited. But what are the differences between the two reviews? Of course, ours was a systematic review and the one from the EQUIC, so in blue, was a rapid report. But apart from that, there were only small differences in eligibility criteria, which you can see here. Both reviews included studies involving patients undergoing primary knee arthroplasty, which compared hospital case volume. The EQUIC was also interested in surgeon case volume, which we were not. However, the EQUIC included only studies adjusted for risk factors and for cluster effects that were published after 2000. This led to the fact that we included 68 and the EQUIC 18 studies. In addition, we conducted a dose-response meta-analysis and the EQUIC described the results. In sum, there were small differences, but both reviews drew the same conclusions. That is to say that there is a hospital volume outcome relationship for total knee arthroplasty. This means that hospitals with higher case volumes do have better outcomes, so there is evidence for a minimum volume standard, even if the exact number of 50 remains a normative number. In this case, there was no contact between decision-making bodies and academia. And the EQUIC report, as I said, did not reference our systematic review. In our view, the presented example clearly represents a case of research waste, especially because both projects were publicly funded, and it demonstrates the research policy gap. On the other hand, there have been many political debates on minimum volume standards in Germany, and two reviews by independent institutions may strengthen the conclusion. Different intentions and legal pathways may also explain the described case. But what could have been different? Starting with us, we could have contacted the GBA when starting the review, or better involve them as stakeholders, because we knew that the topic was important for them. And in a new systematic review on the effects of minimum volume standards, which we are currently conducting at our institute, we do involve the GBA in a project advisory board. We also could have contacted the EQUIC when we knew that they were instructed to perform a rapid report. However, in case of a rapid report, there is no official way for commenting. For full reports, there is a commenting procedure for the report plan and also for the final report, but for rapid reports, this phase is omitted. Looking at the EQUIC, they could of course have contacted us latest when identifying our protocol, which in our view they must have identified with their literature search. However, they also have deadlines, and they cannot just copy our results and extractions because they have to trust them. But we believe that some of the work could have been saved, and in our view they should have discussed the differences of both reviews in their discussion. The described case is special in the way that it is very context-specific because there are few countries with minimum volume standards. One could argue that in this case, the expectation to collaborate should be even higher because it is so context-specific. But one could also argue that the case is a special finding and collaboration may be even more important in other research fields, such as the assessment of surgical procedures or drugs, which are evaluated in a lot of Western countries at the same time. This is another sort of research phase, although not between academia and decision-making bodies. The adoption of regulation on health technology assessments by the European Union regulates that after 2025, member states' HTA bodies will conduct joint clinical assessments of new medicines and certain high-risk medical devices. However, it does not regulate assessment of surgical procedures, but it shows that collaboration between different organizations is possible, and we should think about how this is applicable or transferable to the collaboration between academia and decision-making bodies. In the end, we rather have some questions to you. Since we are aware of other examples of duplicate evidence synthesis, the described case is just an example, and we are wondering how researchers, decision makers, and stakeholders can work together to prevent such scenarios in the future. Are you aware of similar examples in other countries? Are there strategies to prevent such cases in other countries? And in your opinion, in which case one can rely on existing systematic reviews, and when is a new evidence synthesis needed? These are my references. Thank you for being able to present this example of Germany. I'm looking forward to hearing your experiences and of course also your questions.